So my name is Dr. Derrick Buchanan. I'm a fourth-year postdoctoral fellow at Stanford, and I work in the Department of Psychiatry and Behavioral Sciences with Dr. Nolan Williams, who is the inventor of the Stanford Neuromodulation protocol. And if you want to connect with me, I've got my email, Twitter, and any other links, LinkedIn, etc. Via the QR code there. Feel free to connect, or my personal website here. Okay, so I'll give you a quick outline of what we're going to cover today. I want to start with a brief background on myself. I always like to see a little bit of who people are when I'm seeing a talk from them, because I might have read their research, I might have read their papers and seen their stuff, but I have not had the opportunity to meet so many of the people that I get to see. And so I always love to learn a little bit about them. And so I try to offer that as well. And then I'll move into some background on major depression disorder, treatment-resistant depression, rTMS, so transcranial magnetic stimulation, theta burst stimulation, accelerated theta burst, and finally SAINT. So kind of taking us through a background and history on that, and moving into the full kind of guidelines for SAINT on the second half of the talk, in terms of like how to implement SAINT. And I'll kind of assume that everybody here has some background on depression or some background on brain stimulation, but I'm also going to provide hopefully a sufficient background. So if you have no exposure to any of these things, that you should be able to follow along the entire talk here. Just a few disclosures. I am employed by the Stanford Brain Stimulation Lab, but I don't have any financial interest in related to SAINT or Magnus, the company in the United States that is kind of owns or licenses SAINT from Stanford now. I am a founder and shareholder of BaselineNeuro.com and of Royal World Archive, and that's kind of an imaging company. And then Royal World Archive is like a video production company where we actually make scientific videos for new articles and things like that. So if you like that kind of thing, you can check it out, but it has nothing to do with the research, so I don't really have any conflicts of interest with regard to the talk today. So starting off, I grew up in a town called Oshawa. I went to school originally at O'Neill Collegiate and Vocational Institute throughout my childhood, and then moved my way into Ottawa, Canada. So I am from Canada, but I've been at Stanford in California for the last 4 years, and working there, like I said, in psychiatry. But I originally studied my PhD in Ottawa, Canada, and that was also focused on brain stimulation, neuropsychiatry. Originally, I was working with transcranial direct current stimulation, doing pediatric trials with youth with developmental conditions. A lot of the papers, kind of my early career stuff, was focused on this direct current stimulation in pediatrics. So this acceptability paper we published on ADHD, safety and tolerability of TDCS in kids. We published a systematic review there, and then I started thinking more about like depression applications in using brain stimulation. In 2018, I was kind of coming toward the end of my PhD, which was in neuroscience, but ultimately it was kind of like a clinical neuroscience focus, always working with neuropsychiatric patients. And I was at the Royal Ottawa Mental Health Center, where we did a lot of work, and I attended some conferences there. And it was one really powerhouse conference in 2018 where we had two amazing speakers that kind of inspired the next trajectory of my research. So the last 7 years or so now has been focused on transcranial magnetic stimulation. I kind of moved out of TDCS and into TMS. So we had two amazing keynotes. One of them was Dr. John Downer, a Canadian researcher from Toronto, who is, one of the major pioneers and voices of TMS research. I'll talk a little bit about these trials more later, but just kind of highlighting, this was right around when this conference was right around when this trial came out, the 3D trial, which demonstrated the non-inferiority between rTMS 10 hertz and theta burst ITBS. And in the same conference, we had Dr. Connor Liston, which is right around the same time that this Nature Medicine paper came out. That was the resting state connectivity biomarkers. So looking at the subtypes of depression using this like massive neuroimaging database. And that kind of inspired the trajectory of the rest of my career, or at least the last 7 years, and probably the next 7 years at least, in what I've been doing. So then I came to Stanford in 2021, And I was working with or still am working with Dr. Nolan Williams, who was a mentee of Mark George, one of the earliest pioneers of TMS. And now I'm sort of like the grandbaby of the TMS, is how I look at it. So I've kind of come through this hierarchy of mentorship, and really lucky to work with Dr. Williams and learn from him about all these things TMS, and have the opportunity to work in the Stanford Brain Stimulation Lab, where we're doing some amazing TMS research. And after all these years, a few years later, after originally meeting Connor, now we work very closely with Connor, who's a professor at Weill Cornell Medicine in Manhattan. And we have several trials between Stanford and Weill Cornell with Connor that are multi-site trials, and one of which that I'm leading right now, which is what we call our biotype trial. So this is a clinical trial. We're actually in our 5th year. It's going to be ending sometime next year. It's going to be one of the largest TMS trials. So we've recruited, or will aim to recruit, about 348 participants in 3 different treatment arms. This is kind of the first major head-to-head trial of DMPFC versus DLPFC TMS, where we're using a brain scan, this biotype guided prediction, to try to predict which site is optimal for which participant. And this is sort of our lead team. We have a really amazing big team working on this, but Dr. Williams, Dr. Machbadi, Dr. Connor Liston over at Cornell site being the lead PI over there, and myself, the lead postdoc who's been running this trial for the last 4 years. So a really exciting trial. Can't wait to kind of get these results out. But that's sort of where my expertise to TMS comes in. I've been working in the field for 6-7 years, but kind of have now, led thousands of sessions of TMS and brain imaging and so on, and have been working very closely with this team over the last many years. So I just want to take a step back now that I've kind of talked a little bit about where I'm coming from, what my background is with regard to TMS and brain stimulation, and why I'm here talking to you. So taking a step back, I just want to go into talk about major depression disorder. So major depression disorder is characterized by at least 2 weeks of persistent low mood. Typically, at least a month or more is required to kind of see a diagnosis for that. This can be things like loss of pleasure, anhedonic symptoms, and other symptoms like changes in appetite, fatigue, poor concentrations, feeling of worthlessness, recurrent thoughts of death or suicide. And a diagnosis often requires at least 5 or more of these symptoms, including things like depressed mood, anhedonia, significant stress, and some level of impairment. And severe depression can be very impairing and very disabling. And a lot of people are surprised to learn that severe forms of depression is considered by the World Health Organization, using what's called the WHODAS, the World Health Organization Disability Rating Scale, as one of the most disabling conditions, even more disabling than patients undergoing chemotherapy for cancer treatment, even more disabling than somebody who is actively having a heart attack. Like, if you're actively having a heart attack, you can a lot of the time still get in a car and drive yourself to a hospital. If you have really severe depression, you might not even be able to get out of bed, you might not be able to get up to go to work, and you may want to die, unfortunately. And so it's really disabling, and it can be a very fatal condition in terms of kind of suicidality and how that can affect everybody. And the rates of suicide are really terrible statistics when you compare them to even things like car crashes. Last year in the United States, there was around 50,000 deaths by suicide compared to around 40,000 deaths by car crashes. So that's a surprising statistic, both terrible statistics, but often people are surprised to learn about how, kind of disabling and fatal depression can be. And so we need more rapid treatment options. We need better treatment options for depression. And there's also something called treatment-resistant depression, which is when a patient fails to respond to standard antidepressant regimens. So that typically includes things like antidepressant medication, so pharmaceutical treatment, or therapy. And there's many different types of antidepressants, many different types of therapy. The FDA, so the American guidelines, typically requires patients to fail at least 2 antidepressant treatments before they'll allow you to do TMS, or before insurance would approve TMS, or to qualify you for treatment-resistant depression. And so most trials of TMS that are done on individuals who have treatment-resistant depression. And although that's the case, we've published recently this paper. I'll bounce back in a second there. This paper that's making a case for why TMS should be considered a first-line treatment, that there's good evidence that TMS meets all criteria that are set out by the different CANMAT guidelines. Guidelines from Europe, US, and Canada kind of all converge. And based on those guidelines, TMS seems to meet all those criteria, such as having at least a couple randomized controlled double-blinded trials that have been successfully showed clinical meaningful benefit. So it's a faster response, there's less side effects. Like, there's all these reasons to consider TMS as a first line. And hopefully we'll get there, but we're not seeing that happen yet. So looking at some treatment-resistant depression treatment options, if we want to kind of compare against, there's psychiatric drugs, traditional TMS, there's electroconvulsive therapy, and things like esketamine, which has become quite prevalent lately as well. Now, they each have their own advantages and disadvantages. So psychiatric medication can take years or months to find a result that is meaningful to you. It often involves a lot of side effects and a lot of trial and error. Traditional TMS can be quite effective, but it also can take weeks, months, and it's a fairly long time commitment as well. When we'll get into talking about the new accelerated forms, which is where Saint comes in, and these rapid acting options, which are exciting. ECT is actually very effective. Up until recently, it was one of the most effective treatment options for treatment-resistant depression, but it still requires several weeks of treatment. It also requires anesthesia at every treatment. It's kind of a little bit intense to do, but it is a very effective treatment. And then esketamine is taking this twice a week over 4 weeks. And again, it can sometimes require weeks of treatment, time off work. There's certain limitations, like not being able to drive after the treatment. And it does have a very good success rate, though. So we're seeing this kind of shift toward these new treatments, and it's exciting that we're getting there. But I look forward to telling you about sort of these accelerated treatment options. So again, just taking a step back, and in case some of you aren't familiar with what TMS is, so transcranial magnetic stimulation is a non-invasive form of brain stimulation. It uses magnetic fields to stimulate cells in the brain, so we can stimulate neurons. We know through neuroimaging research, like using MRI and fMRI, that certain areas of the brain are affected by mental health conditions. And when that happens, it's typically that some area is overactivated or it's underactivated, and we can reinvigorate those areas by turning them up, or we can turn them down using different pulse patterns of TMS to try to restore that brain activity or inhibit the brain activity, depending on what condition we're treating. TMS was first developed in 1985 by Anthony Barker and some of his colleagues, and then it was first FDA approved for depression in 2008. So I'll go through a timeline of this shortly. To kind of place or give you some context in placing the Brain Stimulation Lab in the field, if you're not familiar with the Stanford Brain Stimulation Lab, we've been around for about 7-8 years now. I joined 4 years ago. In the last 4 years, we've done over 1,000 MRI and fMRI sessions, collecting and that data from many different clinical trials. We've ran over like a dozen different clinical trials. We've done over 20,000 TMS sessions in the last 4 years. And all this is to say is to kind of just position ourselves, and why I'm talking to you about how we think we can offer you some recommendations, because we've done this thousands of times now. And what I hope to offer through this talk is some guidelines, some recommendations, some feedback on our experience that we've had, and ways that you can do this in your lab that might help save you some trouble or some trial and error, some burden, because of what we've learned from different mistakes and all the different trials that we've done. And Ultimately, what I'll end up presenting today will be published soon in Nature Protocols, and so there will be a protocol paper attached to this that you can go and download and follow and have that as a resource, and that is most of what will be covered in the guidelines today. So a little background on TMS in general. So mainly we're going to be talking about major depression, which in the context of the United States, TMS is FDA cleared for major depression disorder, migraines, smoking cessation, obsessive compulsive disorder, chronic pain, pre-surgical cortical mapping for speech and motor areas. If that's not clear, what that means is basically if you are doing surgery, maybe you're going to remove a tumor from the brain, you can use TMS to kind of draw a perimeter around the tumor by looking for activity. If you stimulate a tumor, you're not going to get a response, but if you stimulate the areas that are still active brain tissue, you'll have some responses. And so you can stimulate these areas to make sure that you are not removing any live brain tissue when you're doing something like removing a tumor. So you can do a pre-surgical planning using things like TMS. There's also off-label use of TMS for things like generalized anxiety disorder, post-traumatic stress disorder, post-stroke rehabilitation, tinnitus, bipolar depression, and schizophrenia. And there's many other indications. There's over 2,500 clinical trials currently registered in clinicaltrials.gov. So there's a lot of other indications being investigated, different populations, different age groups, so yeah, like kind of ranging from young children all the way to older adults, cognitive impairment, dementia, and so on. There's many things being investigated right now. Quick timeline of TMS here in terms of some of the major milestones and publications. The original, one of the things I'm highlighting on this slide is the timing. So the shift in the evolution of how the timing of TMS evolved. So how long it takes to do TMS and how rapid TMS can be provide relief of depression. So starting in the original FDA approval, coming from the O'Riordan paper in 2007, led to the 2008 FDA approval. That was the first approval for major depression. This was a 6-week protocol doing 37.5 minutes of TMS per day for 6 weeks. Coming in 2013, we see Brainsway, a company comes online and they do 6 weeks of TMS, but it's 20 minutes a day using this form of deep TMS. And so we see almost a reduction of half the time. So going from 37.5 minutes, now it only takes 20 minutes to do a session of TMS. And then 2016, Neuronetics, another company, they created what they called the DASH protocol. This was another 6-week paradigm, taking about 18.75 minutes. So again, it's slightly shorter duration. In 2018, we see a massive reduction. This was the 3D trial that I referred to earlier from Jonathan Downer's group and Dan Bloomberger and their whole team over there. This was the Lancet paper. And again, 6 weeks, once a day treatment using 3 minutes of intermittent theta burst stimulation. So now we're taking, what they did was they took intermittent theta burst stimulation, which is a 3-minute protocol, versus the original sort of 10 hertz protocol. They did a head-to-head trial and showed that the theta burst was not inferior. In other words, it was basically performing in the same way as the original 10 hertz protocol, and that led to the ITBS FDA approval in 2018. So going from 40 minutes to 3 minutes in about 10 years, and now we can treat a lot more patients because we have a lot more time. We have shorter sessions, so you can get more patients in. And so that was a huge advantage. And through chatting with Dr. Downer, he's really passionate about how do we get more indications? How do we treat more patients? How do we scale this? And he's doing some really amazing work in the US and I mean internationally, really, and in the UK in terms of making these more rapid protocols and shrinking the time. Similar to a lot of the work that we're doing in the Brain Stimulation Lab. So then in 2018 as well, we saw actually the first pilot trial of SAINT, or what would become SAINT, from Dr. Nolan Williams' lab. So my PI of my lab, this was a 1-week version. So all in the same year, we saw that this was a small pilot with six patients. and they actually did 10 sessions of theta burst in a day. It was essentially the equivalent of 6 weeks of TMS in a single day. So it was 10 10-minute sessions of theta burst per day for 5 days. So you end up getting 5 treatment courses, essentially, the equivalent of 5 6-week courses in 5 days. And this was a very rapid acting option of what we started to call accelerated intermittent theta burst stimulation, which wasn't just shortening how long the session took, but shortening the entire window by creating this sort of high dose protocol. So that's mainly what we're going to be talking about today. Then in 2020, we did a larger open label trial. So kind of moved off the pilot trial. We showed that it was feasible, that it was safe in 2018. Then Dr. Nolan Williams, Ellie Cole, and Claudia Tischler, this whole amazing team on the Brain Stimulation Lab in the early years, they did the open label SAINT trial, published in 2020. Then finally, the randomized controlled trial, which was double-blinded, placebo-controlled, was published in 2022. And that was, again, another 1-week version of SAINT. So these 3 trials over that 4-year period. And now even in 2024, we just had a paper come out about using SAINT, a pilot for bipolar. And then finally, in 2025, we see Medicaid, so universal coverage across the nation of the United States, is now covering SAINT almost entirely, which is kind of unheard of in a lot of mental health treatments. It's the first brain-based biomarker approved by the FDA, and we'll talk about what that biomarker is. So there's a few other innovations that happened with SAINT that we'll talk about. That wasn't just the timing, but this was really kind of just to give you an overview of this history and the progression of TMS. Along with this history and the progression, this is basically a table version of the last slide, but focus more on efficacy. So looking at the evolution of the efficacy. So timing improved and the efficacy rapidly improved. So up until 2018, most of those standard versions of TMS, so the DASH protocol, the deep TMS, the standard original FDA approval, the ITBS, they were all having a response of around 50% and a remission around 30%. That's pretty consistent across all these trials, which is quite remarkable still, especially that these were in patients with treatment-resistant depression. So all these trials specifically treating patients who failed to respond to medications and therapy, we now have a good treatment option for them, which is incredible. But come SAINT, we start to see this massive improvement in response and remission, like 70, 80, 90% response rates in just 5 days. In fact, that's typically on an average of 2.5 days is when we're starting to see that response. So we're able to condense this 6-week protocol into a day and get people better very rapidly, which is why it's so important, because we need more rapid acting treatments for individuals with depression, especially those who are feeling suicidal. As I mentioned earlier, we know this can be extremely fatal, and we really need to treat these kind of mental health conditions with a sense of urgency in the same way that we treat physical health conditions with this urgent care. And so we are really excited that this is kind of coming to fruition. If we compare SAINT with some other methods, so on average from the RCT, so the randomized controlled trial, about 79% of patients went into remission, and that was there was 13% of people in the sham condition, which is about the same of what you expect to see compared to pharmacotherapy or other forms of TMS. So it's kind of an amazing result there, and there was quite large effect sizes on this as well. This was published a couple years back in the American Journal of Psychiatry. So again, just another graphic to illustrate or compare against some different treatments. Traditional TMS, maybe about a 15 to 30% remission rates and 50% response, taking about 6 to 9 weeks. So 6 weeks kind of being a standard protocol, but often up to the 9 weeks with like a maintenance or taper. ECT up to 4 weeks with about 70% response, 50% remission. Esketamine about 50%, 60% response in a 4 to 8 week period. And SAINT in just 5 days, getting this kind of massive response. So again, I'm kind of repeating a few things here, but I want to focus this slide on the maintenance protocol. So about 62% of patients maintain their response or remission at 6 months. So if you evaluate patients 6 months after doing SAINT, we see a pretty strong response. And if we do maintenance TMS, then that increases to about 84%. And the standard maintenance protocol, so depending on what you've used in your lab, or if you're considering doing something like this, one that we find quite useful is we administer the quick inventory of depression, or the QID self-report, every 2 weeks. So after a patient finishes SAINT, they can fill this questionnaire at every 2 weeks. And on the 2-week mark, if their questionnaire indicates that they're kind of relapsing into depression, and that stays consistent for 2 rounds of the QID, so that would be 4 weeks. So 2 weeks, mood is dropping, becoming significantly lower. The next 2 weeks, the mood is persistently low. So that's like a month of persistently low mood. That triggers a retreatment, where we would then have the participant come back in and do an additional follow-up. So if you're interested in SAINT, there's a lot of stuff online about it now. Dr. Williams has been on TV, the Today Show, CBC. He's been a lot of news coverage on this, and this was a lot of this was done during early kind of pandemic times, and so you can kind of see the history of that in this photo here. This is the room where SAINT was first developed. We now have several rooms and equipped like this at Stanford in order to accommodate the tens of thousands of sessions that we're doing every year. We've kind of grown our lab and opened up several rooms like this. Stanford also has its own clinic that's independent of our lab, that are kind of similar rooms, all located on campus. So this is a diagram that outlines what SAINT looks like on a weekly basis. So it's 10 10-minute treatments per day over a 10-hour period, and there's a 50-minute interval between that. And in that 50 minutes, a lot of patients will just hang out, rest, take calls, continue their work. So some people think like, wow, a 10-hour day, that it is intensive, but it's not like you don't really even have to take that time off work. Maybe you'd like to, but when we think about some of the trade-offs between 6 weeks of TMS, daily visits, there's some advantages of that. You come in once a day, you're only in the treatment for 15 minutes because it's like a 3-minute session. If you're doing theta burst, that could be convenient, but if you live far from the clinic and you have to commute every day for 6 weeks, that's kind of a burden. If you have to come in for an entire week, that could be seen as a burden, but it's also, a lot of patients will just continue their workday and they just take 10 minutes off every hour and they go into the room and they get their treatment. And it's also good for travel. Like we had people flying from all over the country to come and do the treatment because they would just have to stay for a week. So what SAINT does, there's a few particular things. We talked about the timing, making it more rapid, but there's these different targeting options. And SAINT uses a personalized targeting option that uses a functional magnetic resonance image combined with the accelerated aspect. So that was kind of 2 critical innovations of SAINT, was doing functionally guided TMS as opposed to a different targeting method. So I'll flip back here in a second. So when we see kind of original TMS trials use scalp-based methods where you would locate the hand knob using motor thresholding, and then you would try to locate the DLPFC. So all those trials we looked at on that timeline there, and all the efficacy in that table, they're all targeting the left dorsolateral prefrontal cortex. That's sort of this left prefrontal area of the brain. And there's different ways of targeting that area. One is this scalp-based method. So we find the hand knob, you measure about 5 centimeters, you find your way close to the DLPFC. A second method that's maybe slightly more sophisticated is a craniometric beam F3 method. So it's been coined this term beam F3 because of the researchers who invented that, where it uses scalp measurements similar to what you would do if you're doing EEG or electroencephalography, where you take scalp-based measurements. You can approximate where it is. Then we saw some trials that started using an MRI, so a structural brain image, where you can take an MRI of the brain and find somebody's dorsolateral prefrontal cortex, and then you can use neuronavigation to place a coil there. And then finally, we have the SAINT method, which is the functionally connectivity guided method. So instead of just using an MRI, we use a resting state fMRI, where we look for the area of the left dorsolateral prefrontal cortex that's most anti-correlated with the subgenual anterior cingulate cortex. So if this blue dot is just like a general LDL PFC target, each of these dots is an individual's target. So you can see there's quite a lot of inter-individual variability in where that target is. So this is a big search space, which could be the dorsolateral prefrontal cortex, but each of these dots represents a personalized target. And the closer you get to the personalized target, the more effective the treatment is. And we do that by using this algorithm, and this is that sort of functional biomarker that I talked about. It's the only and first FDA-approved brain-based biomarker for a mental health condition, and it's this biomarker combined with the SAINT treatment that are all approved now by Medicaid based on these SAINT trials. So now I want to get into the kind of timeline, the protocol, the recommendations for how to successfully implement SAINT, and how to do that, based on our experiences. It's helpful to think about SAINT on sort of a 3-week timeline, where in the first week you need to do a rigorous assessment of the patient that you want to treat. On the second week, you're going to do the MRI and fMRI, and on the third week is when you're doing the actual treatment. So week 1, you have to assess the patient for their eligibility. So depending on where you're coming from or what your interest is, maybe you want to do SAINT in a clinical setting, maybe you want to do it in a clinical research setting, like in a controlled trial. This kind of applies in both cases. I'm going to approach it a little bit more from a research perspective, but you can apply these things in a clinical thought as well. So originally, SAINT was designed to treat major depression, but it is being adapted in our lab and by other labs to treat other conditions by looking at other functionally guided targets, or other ways of doing advanced targeting combined with accelerated TMS. And one thing that's really important is having a strict and thorough inclusion-exclusion criteria. So when you're doing clinical trials, the best way to get the most robust signal-to-noise ratio and the best clinical effect is to make sure you're treating the population that you aim to treat. So we want to make sure we're treating individuals who have treatment-resistant major depression disorder, and that major depression disorder is ideally something that is state dependent and maybe not necessarily a trait dependent. So we want to try to define that and tease that apart. We want to make sure that it's not because they have sleep apnea, because somebody with sleep apnea might look like they have depression, but TMS won't fix sleep apnea. They need a CPAP for that. Or if somebody has a thyroid disease, TMS won't fix your thyroid disease, so we should treat you with thyroid medication. So it's like, you want to make sure that if somebody is presenting with depression, that they actually have clinical depression and not something else. Otherwise, you're going to end up having a poor sample. And if you think about it in a research setting, that's really what you would love to see in a clinical setting too. Like, we spend hours evaluating, evaluating participants. Excuse me, because we want to know that we're treating the condition that we hope to be treating. And if you're in a clinical setting, you would hope that your doctor would spend enough time with you to help give you the treatment that's actually going to get you better. So in a research setting, we also use something called the SAFER instrument in addition to standard questionnaires. And the goal is to increase the quality of our trials by kind of helping us separate placebo from responders and having a more homogeneously defined MDD population. So we start off by doing a very rigorous pre-screening where the participants fill out a patient registry. We have like, I don't know, 20 plus thousand participants that have, contacted us to be interested in doing the treatment, and they fill out this pre-screening questionnaire. We use REDCap. We quite like that software if you're interested in kind of how you want to set up a clinic or how you want to set up a research program. We really like using REDCap. It works quite well for all of our needs. So they fill out a bunch of pre-screening information, demographics, quick inventory depression, generalized anxiety, like a lot of standard questionnaires that helps us get an idea of your medical history, psychiatric history, current medications, past medications, so we can see, like, do you appear to, be a good candidate for TMS? And whether or not you have a history of brain stimulation or success with brain stimulation. And then if you kind of pass this pre-screening, then we would move on to doing a formal screening with our psychologist or one of the psychiatrists or both. And that involves doing a formal medical record review. So we'll review medical records for a lot of patients, again, just to make sure we're finding good candidates, that TMS is a right solution for you. And we offer kind of, if you want to see a full list of these, you can look at some of our criteria online and see the protocol paper when it comes out. In week 2, we do the MRI and fMRI. So once we know that somebody's eligible to participate, we schedule them for the MRI and fMRI. We, of course, have to make sure it's safe for them to do fMRI. There are some contraindications, if you have metal in your body, things like that. And it's another important thing is, so first, we make sure we have a homogeneous sample of clearly defined MDD. Then you want to collect high quality imaging data. It's all about like getting this 80% remission rate or 90% remission rate. We do that and achieve that by making sure we get a really good signal to noise ratio. We make sure we collect data from participants who fit the criteria. We make sure that we collect really high quality imaging data. So you want to spend a lot of time making sure your imaging is robust. And so we've done that, and we have certain recommendations for that. So we would then enroll a participant, collect their fMRI data on a Monday so that we have about a week to get the data processed. It typically takes at least a few days to run all the data and generate the target. The minimum requirements for computing a functionally guided target, at least based on our pipeline, is at least 24 minutes of resting state fMRI. And we do 4 6-minute scans so that we can concatenate those, but also have good reliability between the scans. And we then warp that into MNI space using the DLPFC and the SGACC seeds. Let's see. So I might skip over a little bit of this, but if you're interested, you could take a screenshot or kind of think about how we are computing the fMRI. But we want to determine the optimal LDL-PFC subunit. So again, we're searching within the whole LDL-PFC, and we use 3 main factors for that: the net correlation and anti-correlation of the LDL-PFC to the SGACC, the size of the subunit, and the spatial concentration of that subunit. This is kind of the decision model that helps us decide how, which target is best. Once we've generated the target, you've got to upload that to your neuronavigation software in your TMS room so that you're ready for when the participant comes in the next week. Then, so we've done this on a Monday, we spend a few days, we prepare the target, we meet every Friday. So again, you don't have to do things this way, but it's, if you're thinking about running trials like this, I want to help you by recommending things that we've done that we find useful. So we have a meeting every Friday, we call it our next week prep meeting, and we might be running several hundred sessions the next week. Like if we're running 4 participants, that could be 200 sessions we're running in the next week. So we review each participant, we make sure their target's ready, we make sure it's uploaded, we make sure we're all prepared for whatever to expect logistically for those individual participants, what room they're going to be in, what machine they're on, and so on, and just to make sure all of that is prepped. So then thinking about week 3, the treatment week begins. You're going to need certain materials. Again, I'm not going to go through all these list of materials. You could screenshot this as well or check out the paper when it comes out soon. But we use an X100 for MagVenture. Typically, we're using a CB65 coil for the DLPFC targets. We do have several trials where we're targeting the DMPFC, so we use a DB80 for that. You'll need your neuronavigation and all those different accessories and certain consumable materials that just help you set up the room and set up those treatments. There's a lot of logistics. So if we usually start patients at 8 a.m., we ask them to arrive at 7:45 and promptly begin at 8 because it's a 10-hour day, and we got to get people in and out. We stagger participants usually every 20-minute block. So if we're running multiple people on a machine, But if you're doing different target sites like LDL-PFC and DMPFC, then we usually, what we do and what we would recommend is putting people on different machines, because it's a lot easier. It saves you time. Every time you unplug the coil, it causes wear and tear on the machine, and you have to reset your neuronavigation, which adds more time. So if you really want to be able to get people in and get people out and run hundreds of sessions, it's easiest to have them on a different machine. We also typically start off at a low motor threshold on day one, a low treatment threshold based on like around 40% of their resting motor threshold. And then we ramp up a few percent every train until we get them up to their full dose. And we just get them, a lot of that's based on tolerability, because some participants have some tolerability issues on the scalp. So we want to ramp them up, and as long as they feel comfortable, we'll continue to move that up. We get a lot of questions about, how do you do a 10-hour day? There's a lot of ways to do that. We found that the best way is to people can work a standard 8-hour shift, but we stagger them a little bit where they're doing basically 2 sets of 5-hour shifts. So one group of people one group of staff is treating for 5 hours, and then they have a few hours of their day where they're working on other things so they can write papers and work on other data. And then another group is there for the second half of those 5 hours, and there's a little bit of overlap there. That's what we found has worked best, but there's of course a lot of ways you could do that. You could do 10-hour day and only work 4 days a week, but labor laws in different places. So I was talking about tolerability. We published this paper about tolerability. We know that can be an issue for some, especially in the DMPFC area. If you're interested, it was published in Brain Stimulation last year. We found basically that just over-the-counter medication, Advil, Tylenol, like acetaminophen or ibuprofen, seems to have the best help on that. Ice packs, a little bit. Anecdotally, I've seen ice packs work quite well. In this pilot, I think our data wasn't as robust as it could have been in terms of how we use the ice pack, but putting an ice pack for 5 or 10 minutes over the treatment site and then placing the coil there immediately. So take the ice pack off right before treatment and placing it. I've seen that help a lot of individuals. Okay, almost done here. I want to make sure we save time for questions. So we want to think about what are some of the anticipated results? So if you do SAINT, what can you maybe expect? So first of all, if we're thinking about week 1, this is mainly based on recruitment and enrollment. Every 10 participants who you fill out a pre-screening info, you might expect that maybe 4 will meet your screening criteria. So you'll actually schedule 4 assessments for every maybe 10 people. And of those 4 assessments, maybe 2 would actually be enrolled into your trial. 2, sometimes 1, depending on how strict the criteria are. So for example, in the initial SAINT RCT, we had 182 potential participants who completed pre-screening questionnaires. 54 had a full screening and 30 were enrolled. And this is a really critical conversion number, because you save a lot of time of your psychologist. Instead of having a psychologist do 182 assessments, we rigorously look at those pre-screenings. That's why the pre-screening criteria is so important, because we save a lot of time. Even if we have to spend an hour reviewing that, it's a lot better than having a psychologist spend 2 or 3 hours doing a full assessment. And then 30 were enrolled of those numbers. So anticipated results for the MRI, there's several targets that will be generated. We've published several papers on this, so I'll highlight a few. There was this paper in PNAS that came out a couple years ago, targeted neurostimulation versus a spatial temporal biomarker. So basically we found that this was a spatial temporal marker that showed after TMS, after SAINT, the SGACC LDL-PFC marker kind of flipped and reversed, and that the patients who responded showed this flip. The couple who didn't respond didn't have that flip. So it was kind of a full circle testing of this biomarker that we showed that not only do we find a biomarker, we can actually treat it and reverse a signal, and that is highly correlated to a clinical response. So it's really a full circle on how you would test a biomarker. Can you find something and then actually treat it, and then it actually gets better, and it's related to clinical outcomes. So this was a really great finding. Then we had another paper, the increased anti-correlation between the left dorsolateral prefrontal cortex and the default mode network following Stanford Neuromodulation Therapy. I'll also just note there's two different terms. They're kind of the same. They're both trademarked by Magnus. The company that licensed SAINT is SAINT, the Stanford Accelerated Intelligent Neuromodulation Therapy, or SAINT, or SNT, Stanford Neuromodulation Therapy. They are referring to the same thing. For various reasons, they're kind of used in the literature differently, or not differently, but in different contexts. We use S&T, and typically in a corporate setting, we're calling it SAINT, and then in like the literature, we're now referring to it as S&T, because some reviewers didn't like the term SAINT because of its connotations, I guess. So that was published in Nature Mental Health, and there's also this other paper from Translational Psychiatry that showed the SAINT effect on the amygdala, DMPFC, so different functional connectivity changes. So for sake of time, I'll just kind of brush through this. And then finally, the last thing about anticipated results is if you're using SAINT, you can expect hopefully about 70 to 90% of patients to reach remission criteria. And this is based on the RCT findings published in AJP in 2022. We also published this paper in Nature Mental Health last year that looked at predicting outcomes of SAINT. So we found that lassitude, which is one of the items on the MADRS, was highly predictive of SAINT outcomes. So early changes. So on day 2, we saw this early separation, a significant separation of lassitude was predictive of overall outcomes of SAINT. In terms of durability, it appears to have strong durability, where 6 months on average, participants are still, having a good response to SAINT, and that retreatment works quite well, and that's quite robust, and stronger efficacy compared to like the 3D trial or some of the other TMS trials that have been done. And finally, just some final recommendations. We know recruitment's hard, so we recommend, if you have the opportunity to have a patient registry, to have a pre-screening database, like this really helps to triage people. And I can't emphasize enough how important the IE criteria is, and just actually spending a lot of time pre-screening people, advertising on Facebook, advertising on Instagram. We get a lot of people that just come to us because they see our ads, and doctor referrals. So referrals that come right from doctors tends to be one of the highest conversion rates for us, in terms of, every 10 people we get from Instagram maybe leads to 1 participant enrolled. Every 10 people we get from doctors maybe leads to like 4 people enrolled. So it's like a higher conversion rate. Try to have this workflow like I presented, have these meetings set up where you review patients, you have a next week prep, you know what timing, when you want to get a participant in the scanner so you can get the target, so you can get them started. And we build these amazing teams around each of these trials, and the structure of our team is typically that there's a lead medical doctor, or typically that's the PI. Then we usually have a lead postdoc who kind of runs the trial and is responsible for a lot of the hands-on stuff. And then typically at least 1 research coordinator who manages all the patient appointments, and then a big team around that as well. But that's kind of the structure we use. Once somebody's enrolled, we give them a welcome packet, which is like a big information packet that tells them everything they need to know, where to go, what room they're in, who to call, what they, everything that they need to know about the trial, that really helps us mitigate their, enhance their experience, mitigate dropouts by, making their experience as good as possible, mitigating their pain, and then having an open label follow-up option. If you're doing an RCT, a lot of patients are more inclined to do the RCT if they think that they have an option to come back for an open label treatment in case they don't respond to treatment. And final take-home message here is, try to streamline your recruitment efforts, spend a lot of time on the IE criteria, build strong teams. And if you'd like to learn more, there's really amazing episode with Dr. Williams on Andrew Huberman. You can check out our website. You can go to any of these, TV screenings. And yeah, I appreciate your time, and thanks so much for listening. And I'm happy to stick around. I'm sorry I went right to the end, but hopefully we still have some time for questions.